Can you elaborate on the factors that might explain the variability of Candida auris reduction despite significant decreases in fungal and aerobic bacteria CFUs?
To me, the overarching piece is we've shown in hospital settings and acute care and outside of acute care, and frankly, in long-term care facilities, that this technology reduces the bacteria and fungal burden that then results in less infection of the residents or patients in those rooms or in those settings. As we do that, they always have a question of, well, this is the one we're really worried about. What do you do to this one? It's such a critical study because it was an institution that had a significant problem with Candida auris and had significant colonization of their patients. And so they had that concern. They had been measuring it. They heard about our technology. They brought it in, and we had this significant impact on the environment of persistent Candida auris. But by that time, they had people who were shedding. And so in the rooms without active cases, there was dramatic decline. But even in rooms with active cases, there was a decline. Why is that important? Because healthcare providers are picking it up in the active room, no matter how well they gowned, and it comes out into the environment and is infecting another patient. So changing the actual bioburden of Candida auris in a patient's room that is already colonized and infected is an incredibly big deal. It's probably the biggest, what we call stress test for how well the equipment works.
We design surveillance of the environment. We pick the rooms and the surfaces that we're going to swab, and that stays consistent throughout the study, as you would expect it would, right? So there is consistency in where we measure. But what acutely is happening in that environment, as Dr. Birx explained, it's very dynamic. And so we inevitably will see through these surveillance measurements. It's not uncommon that sometimes you will see certain pathogens or microorganisms that you're specifically measuring. You'll see tiny spikes, right? And I suspect if we had continued doing measurements, because we've also seen that then you come back 30 days and what you had seen before had declined, right? Because you're dealing with some sort of acute increase. But what we've never seen is a return to baseline levels of contamination. Because remember, we go into these environments that are all being terminally cleaned with enhanced disinfectants, sterilants, being daily cleaned, even cleaned multiple times a day. So we're going into environments with really rigorous EVS protocols. And yet, the baseline that we see across whatever microorganisms we choose to kind of observe is always significantly higher than after we install the technology. And where you may see little blips in the future, we don't ever see a return to that baseline. Environment is always our leading indicators, and then patient outcomes, which is, we can all agree, the most important things are our lagging indicators, and we always see the same pattern in our different study sites, which is very encouraging.
I know we just kind of touched on patient outcomes, and since patients' health is the most important to us, Amy, is there any other aspects that you envision this technology will help with patient outcomes in these high acute healthcare settings?
We're measuring outcomes over truly longitudinal periods, right? And this is where, to Dr. Birx's point on prevention, I think a lot of the reasons why prevention doesn't get the attention that it should is that most of the mechanisms for prevention require a lot of human participation. And so when you have anything that requires a lot of human participation, and I can say this as a human, we tend to wane, right? Our discipline, our best efforts, you see that decline over time. But in all of our study sites, because we never take the technology out, we continue to get more and more patient data. We continue to see how we are impacting infection rates over time. And we are sustaining 60 and 70% reductions across the spectrum of healthcare associated infections. So to me, what is exciting is that the nature of our technology being ingratiated with the environment means it allows us to continue to learn and be informed over time. It also allows us to say to the world, we're standing the test of time. Because this technology is working behind the scenes 24/7, it is something that any environment that you put it into naturally becomes more fault tolerant. And as Dr. Birx says, because there's no development of resistance, there's a complete agnostic nature of the technology to microorganisms, it really does become broad spectrum and sustainable prevention. So I think finally we all agree prevention is important, but it's always, I think, seemed as somehow unfeasible because of what it demands of us. I think this technology has solved that.
When you're in the hospital and a patient gets a severe infection, you just want them to live. And so you give all of this antibiotics, but you're really not attentive to this is going to mean to that 75-year-old that they lose 20% of their muscle mass because they're in bed an extra 5 to 10 days. That this is going to put them up for a higher risk of fall when they go home. I mean, all of these consequences that when we're acutely working with patients, we're just working to make sure that they survive. And I think what this technology says is every patient now can thrive because you don't do that debilitating piece that you have to do to save their lives. That by preventing it, people can come into the hospital, get what needs to be done. Yes, if they come in for X, that X is taken care of and they don't get Y, and they go home and they can thrive. And I think as our population ages, preventing falls, having people survive and thrive really is important to me. And I think what this says to every hospital is this technology is not only cost effective, but will change the outcomes of your community in allowing your community not only to be more healthy, but to be more functional every day.
If any, what are some of the challenges that maybe you've already seen or you foresee happening with this new ActivePure technology?
To be honest, to me, the biggest challenge is what happened during COVID, because a lot of technologies came out that were not tested, that went on the internet and promised all of these things and caused everybody to question this type of technology and tries to relate us to this or that. And we're none of those things. I mean, we're going after bacterial and fungal cell walls, full stop. We can be additive to anything, but I think that explosion in the space really caused a lot of people to be very skeptical about any kind of new prevention technology. And I think that has been our biggest barrier because people sold things that didn't actually work. It hurt the entire field, and it's a struggle to really get people. But I'm glad the company's committed to doing the science and the data to prove that we're different and we actually are effective.
The best part about it, though, if enduring that season, which we did, and a lot of R&D. We have not only the AGIC publication, but the +1 publication that just came out that dug really deep into safety. That was all in response to the skepticism that Dr. Birx mentions there. So in some respects, while it wasn't necessarily enjoyable to be doubted, it forced a rigor in our own inspection of our technology that now where we stand, I don't see a lot of other infection prevention technologies who have our compendium of data. So at the time you had to sort of just grind your way through it all, but now it's like, well, look what it produced. And more importantly, the individuals who speak the most about our technology in the field are clinicians. So Dr. Birx and I don't really spend that much time anymore talking to health systems, because when a health system shows interest, we say, please call Dr. So-and-so. Let's connect you to a peer, because to Dr. Birx's point, that's the most valuable voice you can hear it from.